Okay, so we've assessed orientation, level of consciousness. We've assessed eyes. Now we're going to talk about assessing motor function. So we want to assess, what does that patient do spontaneously? Do they move all of their limbs spontaneously? Do they move those limbs in response to commands? Do they move symmetrically? So do they move both arms, both legs? We want to assess if our patient is able, whether our patient is able to sit and hold their body upright. Do they have stability, or do they fall to one side or slide out of the chair? Okay. We want to assess balance, and if they're able to stand, and if they're able to walk. And then if they're able to walk, we want to assess their gait. There are some specific gaits that can trigger suspicion for specific neurologic issues. If the patient has difficulty with heel to toe walking, they may have a cerebellar dysfunction. If they have a shuffling gait, kind of leaning forward, shuffling, that's often associated with Parkinson's. So there are some specific gaits that we look at. We assess for increased or decreased muscle tone. So when you assess your patient, you can feel their muscle tone, right? So if a muscle is much more loose and floppy, more lax than it should be, that's going to be decreased muscle tone if they're not able to increase that muscle tone. So your patient who maybe can't sit upright, that may be because of decreased muscle tone in the trunk. We also assess for increased muscle tone. Increased muscle tone can be spasticity. Those muscles are always too tight and spasmed. We assess for repetitive movements like tics or seizure activity. We assess whether they can follow motor commands. We assess for posturing. And we talked about decorticate and decerebrate posturing. Decorticate is also called flexion posturing. Decerebrate is extension posturing. If they are posturing and it is flexion posturing, the injury is more likely to be above the brainstem. If it is extension posturing, it's more likely to be midbrain or brainstem dysfunction. Posturing usually occurs in response to some kind of noxious stimulus or to pain. So patients may posture to a loud noise. Reflexes can have some value in assessing specific conditions. And we look at their protective reflexes like cough, blink, gag. If they have a blink reflex, they can protect their eyes. If they have cough and gag reflexes, they're more likely to be able to protect their airway. If your patient does not have a gag reflex or cough reflex, you should not be putting things in their mouth. But then deep tendon reflexes can, and some other reflexes like the grasp reflex, things like that, can also be helpful in assessing in specific conditions. Diagnostic procedures that may be connected to neurologic assessment, and I want you to use your Pagana. Where's my Pagana? Maybe my Pagana is not in here, maybe in the classroom. So use your Pagana to look these up. So an EEG or electroencephalogram, you're used to an EKG that monitors the electrical signals of the heart. EEG monitors electrical signals in the brain and records those. So an EEG can show brain function. It's very helpful in showing seizure activity. Spinal fluid examination, spinal fluid can be removed by lumbar puncture, and it can be assessed for a lot of different things. Infection, does it have the correct components? Some cancers may invade the spinal fluid, so spinal fluid can be examined. Auditory and visual evoked potentials. In young infants or in people who are not able to give a verbal response, it can help determine their capacity for sight and hearing. So the hearing screen is actually auditory evoked potential. They they have a little mini EEG monitor. It just is looking at that specific part of the brain and whether there's an electric response. A sound is sent in, is applied, and then they're looking for a response on the electrical signals. So that can help determine whether that person has the capacity for sight or hearing. We cannot see brains. And so when the brain needs to be assessed, imaging is often used. So CTs and MRIs are really frequently used. They see different, or they visualize, they provide images of different types of tissue differently. So a patient who has maybe suspected vascular or tumor issue in the brain may get both because they're seeing different things on those. Okay, so you need to know what's a CT, what's an MRI. CT that's done with contrast. Remember that contrast can be hard on the kidneys, so they want to know BU and creatinine, particularly they want to know creatinine. It also is an allergy risk. MRI, the contrast is gadolinium. Okay, so you want to look at potential risk of that. Sometimes they get CT or MRI both with and without contrast. So one thing to know is with children or with patients who are not able to be cooperative and be still, some diagnostic testing requires sedation. All right, so in the next section, we're going to talk about increased intracranial pressure and what that means, because that's something that we have to address with a lot of different neurologic problems.